Good evening to all the viewers who are watching live and will be watching on the recorded version. This is me, Dr. Mukherjee, with you all. And once again, I want to tell you that since we are starting on time, maybe the stream may come with a delay of 30 seconds or 10 to 15 seconds. It's maybe there. And so let's just inform one thing from 8/5 onwards, the auto e-participation certificate link will be live, so you can get that link. The link is in the description below. You can get your auto generated e-participation certificate after filling up some details on that Google form link. So with the we have like wasted 1 minute or more, so without wasting any more time, let's just jump into our 30 seconds countdown time.
Good evening, everybody. Welcome in our online CME 141st episode, organized by National Institute of Homoeopathy Alumni Association. From tonight onwards, we'll be having our co-host, Dr. Hena Siddiq, but she is facing some challenges in Delhi, power supply. So she will be joining with us any moment. And we are missing our beloved senior, our beloved former president, Dr. Debnaran Kalyani, sir. But with all the blessings of our seniors who are inspiring us day in, day out, and love from our contemporaries and well wishes from all our juniors, we are in the 141st episode. In this platform, we invite all our alumni across the globe. Everyone is established in any form. Whatever they are doing it in a great way because we all are NHians and we are proud of it. So we request the NIH alumni to come forward and share your experiences, be it clinical, be it academic, be it administrative, or be it any life events. Be in this CME where we can help each other to learn and grow, and thus to develop homeopathy in the coming decades. Now I'll request our inaugurator tonight, who is again a young, dynamic, just budding doctor from 30th batch of BHMS of National Institute of Homeopathy, now doing PG at Kolkata Homeopathic Medical College and Hospital, our beloved Dr. Robin Sarkar, to inaugurate tonight's CME.
Thank you, sir. Thank you.
Stage is all yours, Dr.
Thank you, sir. It's my great opportunity to be a part of this CME session 141. And myself, Dr. Robin Sarkar, 30 batch BHMS, now doing PGD, first year PGD at the Department of Pediatrics at Kolkata Homeopathy Medical College and Hospital. It's my pleasure to introduce today our speaker for today's CME session, Dr. Argha Chatterjee, 22nd batch BHMS, NIH Kolkata. And today's topic is a case presentation, leg ulcer and foot gangrene. And we know that gangrene is a medical emergency in the talks of allopathic treatment, but in homeopathy, we have super effective medicines to handle this case like foot gangrene. There are many medicines in our homeopathy, and which will be given after tolerity of symptoms. Normally, there are some types of gangrene, that is dry, wet, and gas gangrene. There is dry gangrene, that is there is no bacterial infection. There is only the death of living tissue due to blockage of blood supply, just like PAT, peripheral artery disease. When this dead tissue will be infected by bacteria, then it will be wet gangrene. And gas gangrene is most severe form of this wet gangrene, that is gas gangrene. So Dr. Chatterjee will discuss thoroughly in this topic, leg ulcer and foot gangrene. Now it's my great pleasure to introduce our respected moderator, ma'am, Dr. Akshaya Prakash ma'am, Assistant Professor, Department of Organon Medicine, NIH, Kolkata. Now please ma'am, welcome, and please take over the stage and please guide the today's CME session.
Thank you, Robin, for your inaugural speech. Good evening, everyone. It's my privilege to welcome you all to the today's CME session on the topic of leg ulcers and foot gangrene, which is a topic of very important clinical significance due to its the patient's morbidity, so quality of life of the patient, and also the healthcare burden. As you all know, the leg ulcers and the gangrene are often manifestations of some underlying conditions. It can be vascular, metabolic, infectious, or systemic disorders. And their successful management requires timely diagnosis, careful evaluation of etiological factors, and a multidisciplinary approach. And I'm sure that today's presentation will provide us with an opportunity to review the clinical features, diagnostic workup, and management strategies associated with these challenging conditions. As clinicians, we all are frequently facing these conditions, especially these chronic wounds of the lower limb and understanding. We also want to understand their pathogenesis and management. In order to prevent the complications, it is very much essential. And I'm confident that the discussion will be both informative and academically enriching for all of us. Now it's time to welcome our presenter, speaker of today's session, Dr. Argha Chatterjee, to begin the presentation. Welcome, Dr. Argha.
Good evening, everyone. I would like to first thank the NIH Alumni Association, that is our alumni association, for giving me the opportunity to present these two cases of mine. I would like to thank Dr. Ravin Sarkar for inaugurating the whole program, and I would like to thank Dr. Akshaya Prakash for being the moderator of this session. Today, our session is going to be very brief, concise, and will rotate on the very topic of leg ulcer and foot gangrene. So, without wasting further time, let's start with the case. Orca, can we have the leg cut ulcer presentation on the screen? Yes. Go to the second slide. No. The other one. Yes, this one. Second page. Yes. So the first question is, why is this presentation important? Because this kind of ulceration and basically the cases when this progress to gangrene are very much important to tackle, where the time is of vital importance. Because if we don't get sufficient amount of time in those cases, what happens is that a patient can face amputation. In this case, basically we have a traumatic injury of a farmer where there is a rapid abscess formation. The trauma was from a uh, I should shift. Okay, just give me 1 second. I can send you. Okay. Yes, yes, I'm here. So basically, the reason this presentation is of importance is because this is a case of a farmer who had a injury with a snail shell of a snail, which got stuck in his foot while he was working in the fields. He instantly put that shell out of his foot, but on the subsequent day there was an abscess formation in the area. What it did, what the injury did, we will see further. So when this thing happened, this abscess formation was there, he went to a nearby doctor who basically cleaned the abscess. He put an incision and he drained whatever the pus was there on the subsequent day. But after that, we will see what happens. Next slide. As we said, this is a basically snail shell injury while walking barefoot in the fields. And since he is a farmer, even after the injury, even after picking out the shell, he was walking still barefoot in the field, which causes infection in the injured area and which subsequently formed this abscess. Uh, just give me yes. So during that time, when he went to the doctor, this debridement was performed, and the condition, though it should have been better, it wasn't. Next slide. As I said, the foreign body was immediately extracted by the farmer itself, but the highly contaminated organic debris initiated a rapid tissue infection, and there was within 24 hours there was abscess development. So now the patient, after having this incision over the abscess, after the pus being drained, it's now 7 days, and now the patient is coming to our clinic. Next slide. Next slide. So basically, there was a small surgery done, and after that, patient developed gangrene. This is the place where he came to my clinic. Can we zoom in on the picture, Orko? Can we zoom in the picture? Okay, it's on the screen. You can see very well how the portion, how is the thumb finger of the left foot is looking, and we can, on the below image, we can also see the abscess which is present there, still present there. So we start from there. So when this patient came to my clinic, basically what I saw, that there was a gangrene, there was a septic wound, there was tissue necrosis, there was threatened tissue loss, and there was a high risk of amputation in this case. Go to the next slide. The main goals of my treatment was to arrest the progression of this gangrene, to improve the vitality of the patient, and to promote granulation tissue. Next slide. In this, basically, I have prepared a means graph. Day 0, when the trauma was happened, basically barefoot snail shell puncture, environmental contamination from the soil. 24 hours later, there was acute sepsis, there was abscess formation, which was drained. Then, which was this surgical intervention done within 72 hours of the injury itself. And then, after the surgery, almost 8 days into the gangrene formation, this patient came to me. Next slide. Now, this is basically the most controversial part of the slide. You will see a series of medicines which has been prescribed over the period of time. I started with carbovesh 10m and then suddenly switched to pyrogen 10m. After that, I used Alkamara, then used Silesia, which failed as it is written on the slide itself. Then I had used arsenic alba, then I had used Huangnan. After that, I used Hipasulf, and lastly Calcarea sulf. So why these medicines were used, I will keep on telling step by step. Let's go to the next slide. So when the person came to me, as you can remember from the first slide I showed you, that there was a gangrenous state. So basically, to produce more oxygenation to the area, because at that time there wasn't so much pus present in the area. The sepsis was there, the fever was coming, but the first my priority was to address the gangrene itself. So I prescribed Carbovesh 10 now, the second question I will answer later. Why 10M? I will answer at the last of this slide presentation itself. So I prescribed Carbovesh 10M. There was black discoloration over the tissue. There was threatened tissue that low vitality was there. And after that, after giving Carbovesh 10M, we will see what occurs in the next slide. Change the slide. As you can see, after giving carbohydrate tenum, you can see the black portion, the tissue, necrotic tissue which was there, the gangrenous part has gone out. There's muscles visible. There's a slight that yellow slight small portion that you are seeing, that's also visible there. There is a small portion which is gangrenous still present in the foot, which is not right now visible in this slide, but the gangrene has reduced to a very high extent. Now we have to basically address the septicemia, which is in vital to the case. Patient was having high fever at around 102 degrees to 102.5 degrees Fahrenheit. So at that time there was septicemia was imminent. So for this, to reduce the sepsis, to reduce the infection of the patient, the second medicine came into being. So next slide. As you can see, I've again put in a zoomed image of this thing. As a follow up it's seen, you can see the changes in the patient's grade 2. Next slide. Then we come to the next medicine, pyrogen 10M. Again, the potency I will discuss at the last of the presentation. Why did I choose pyrogen? It's very evident from the case itself. There was high fever, there was a septic wound, and there was a toxemic state. Simple observation, simple medicine, I gave pyrogen. And after pyrogen, what occurred is that fever improved with the prescription. The fever, which was going up to 102 degree Fahrenheit, came down to almost 99 to 99.5 degrees centigrade, which is also coming down without the use of any allopathic medicine, antibiotic or paracetamol. Right now, from the start, from the time the patient has started Carbovesh 10M, he is not on any antibiotics. He has been taking only paracetamol for the fever. After giving pyrogen 10M, since his fever is controlled, paracetamol is also closed. He is not taking paracetamol even. Now, after prescribing pyrogen, let's see the follow-up. Next slide. If you can see the grade 2, you will see a very small portion of gangrenous portion is still there. This is the wet gangrene. There is infection present. This is a wet gangrene. So you can see this black portion present there, which is again a thing of concern, which is worrying, which is made me worry. Because if this gangrene spreads again, he can lose the toe. So with after pyrogen 10M, there is, you can see there is still improvement in. You can see there is a very much improvement in the wound itself. The place, the way it was, it has been better. You can see granulation tissue in many parts of the wound. There is still pus formation there. You can see in all the great top area, there is still pus formation, but granulation tissue is also present. And gangrene tissue is to a very small extent, which was, if you can remember in the second photos that I showed you, it was almost hanging out. Let's go to the next slide. Now came the part which where the case turned for the bad part. So after now the fever is in control. Now the gangrene part is very much less, but there is pus oozing out from the abscess portion. For this, the first thing I came taken into consideration is that there is an abscess formation which occurred while walking on wet soil itself, which is in a damp weather. Taking into all the teachings that I have heard, I've understood what I applied. I started with Dalkamara. Now, Dalkamara was a total failure. As you can see, that there was no appreciable response after giving Dalkamara. Next slide. Again, after that, as a normal prescription, I prescribe Silesia to drain out the pus. That is the most simplest thing I did. My only goal was to drain the abscess as soon as possible, so that the healthy tissue will keep on coming. So, but with Silesia also, there was a failure, and there was no appreciable response. After that, I went to the next medicine. Next slide. As we can see, there's no image in this. During this time, if you can see the Dalkamara image also, one time just go to the Dalkamara slide now, two slides above. Yes, as you can see in this image, if my whole screen is not obstructing your view, কোথায় গেল? হ্যাঁ, yes, yes. If my now you can see this is the state after Dalkama has been given. You can see the black part which was there in the previous photo. Now it has increased little bit, not too much, but it has increased. And even with Silesia, it was still there and was going getting increase in size. So again, two slides down, please. Yes. So basically, where there is a persistent ulceration, there is a continued discharge, there is tissue loss, there is deep wound cavity, I had prescribed arsenic alba this time. Now, I had a very good experience with arsenic alba in the next case, which I will show on gangrene itself. In food gangrene, arsenic alba has a very good role. So I had prescribed arsenic alba on very few symptoms. The first one was a gangrenous change. Second, the patient was chilly, and the third was his thirst. These are the only three things I had considered for giving arsenic alba. And after giving arsenic alba 0/4, I had given for basically 8 days, not 16 days. I had given only for 8 days, 2 doses in a day. So let's see what happens after arsenic alba. So next slide, again next slide, before maggot formation. Next slide, yes. So after arsenic alba, this was the state. You can see the gangrene is the black portion is now whitish. There is only pus in this whole scenario. There is not so much gangrene present. And during this, what happened before this arsenic state, before giving this arsenic alba, another thing what occurred is that there was so much pus formation in this area that he visited another surgeon in his local area, because my clinic is very far from his native place. From the place he was residing, my clinic is very far away. So I told him to visit some local doctor for the wound assessment itself. So when the local surgeon saw the previous image, means previous state, he simply advised that he needs to ampute that grade 2 itself, along with some part of the foot itself, because that's the only treatment they can give. He prescribed some antibiotics, but he said, no, nothing is necessary. Please get the test done, and after that, we will ampute this part. So during this time, and another thing is that during this whole process, what two things were constantly common. One was saline with normal dressing, and another thing which I had advised was a dressing with calendula mother tincture. So this was continuously going around, and during this time itself, this was the changes. And before that, we will see when arsenic had already done his job. You can see the black part is now not there. During this part, there was maggot formation. Previous slide. Now this is again one part it was a good sign, one part it's a bad sign. Whenever there is a maggot formation, it means that there is healthy tissue is now present there, and multiple maggots were there. Almost 30 to 40 maggots were in the means whole injury area. Even in they were inside. So during this time, what I addressed was not just with homeopathy, but also I took into wound management. It was my biggest concern. So during this time, as I said, I had advice for normal saline and calendula mother tincture dressing. But during this time, when there was a maggot formation, I had also advised to dress it with hydrogen peroxide, to wash the area with hydrogen peroxide. Now, hydrogen peroxide kills both healthy and dead tissues. So, after using hydrogen peroxide, washing the wound area with hydrogen peroxide, there were at least 30 to 40 maggots came out. But after that, the wound was a lot cleaner, as we can see in the next slide. Next slide. Yes. So you can see the wound is much cleaner now. And this is the time patient, there was a deep abscess pocket which was built just below the great toe. The it was very much painful. The pus was coming out 3 to 4 times a day, and whenever the pus was coming out, the patient was feeling a little bit better. But at the same time, it was very painful and very much tender at that time. So, taking into that consideration, we went to the next medicine. Next slide, please. In this HEPA sulfur slide, if you can see the great toe properly, the pinkish, you will see there is a pinkish yellowish fluid coming out, oozing out from the base of the great toe. I hope no one had dinner right now because this is quite gross. So this kind of pus was coming out, and it was highly tender. Patient even putting the his foot on the bed itself was very much difficult. He was in tremendous amount of pain. But the very good thing about this patient, so much cooperative that even in this kind of pain, he did not want to have any paracetamol or any kind of painkillers. So at this time, I had given him Hippasol. As we can see, there is an active suppuration, there is marked tenderness, and there is persistent discharge. So I had prescribed Hippasol, and after Hippasol, we will see what happens. Next slide. You can see it has means you can see there's appreciable change in the whole wound. You can see the granulation tissue very good. You can see the wound healing from the dorsum of foot. If you see just on the base of the great toe, you will see it has there is a dry portion where it is almost dried up. And in this kind of scenario, HEPA sulf has done good, but still, pus, the tenderness had decreased, the pain has decreased, but pus is still coming out. So we move to the next medicine. Next slide. Now, this is the final medicine he was put on. Calcarea sulf was prescribed. Now, basically, calcarea sulf I had prescribed just to clean out all the pus which is remaining. And calcarea sulf did its work very efficiently. As you can see, how much wound has become more clear. There is no more pus coming out. Only transudative fluid is coming out. That is a clean, thin, watery fluid which is coming out, which is a very good sign of healthy tissue or granulation tissue formation. Patient was at one point worried about this discharge of transudative fluid, this clean, clear, watery fluid. But when explained that it is good for actually healing, he was very much assured. And from this part, we can see it is going only better. Now, no change in medicine is done. So let's go to the next slide. Local therapy basically sustains the healing. Systemic protocols were given. Normal saline wash along with calendula and hydrogen peroxide at certain point of time for 2 to 3 days was used to remove maggots. Now it can be that calendula and Escherichia medicines like that may have got the power to even pull out maggots from this kind of infected wound. But the thing of hydrogen peroxide, the only reason to use hydrogen peroxide in this kind of scenario is because of only one part. If this patient progresses towards worse in that scenario, he was going for amputation. He in that spontaneity, in that very second, in that very day on which he was very much worried that he want means when the surgeon had told him that he needs to go for an amputation, I just told him, even after 1 week, go to the same surgeon and show him the wound. And at that time maggots were there, means just on Wednesday maybe the maggots were there. So at that time I had advice for washing the wound with hydrogen peroxide to kill the maggots, to get all the maggots out. So basically calendula, mother dressing and normal saline irrigation was done. Next slide. As we can see, this is now the before and after stage of the wound. Even further wound photographs are still present. Now if we go to the next slide, if we see this graph, basically there was a steady decline. When the patient came to me, he was in with a gangrene on his great toe. So to arrest that gangrene, carbovesh 10 and pyrogen 10 was given. After which the wound had improved and then went to a stagnant phase. During this stagnant phase, I had given him Dalcamara 200 and Silesia 30, not together, one after the other. Because Dalcamara had failed, then Silesia had also failed. Silesia 30 I had given in repeated doses, but there was no appreciable response. And then there was also a maggot formation present at that time. Then, sorry, maggot formation came after. And after that, since Silesia failed, and then there was a still small portion of gangrene still remaining on the great toe, I had given arsenic alba. From arsenic alba, oh, we did not talk about Huangnan. After the arsenic alba, there was one point I missed, that after arsenic alba, the good part was that the gangrene part was gone. But since the abscess was there and it was of putrid smell, means it was smelling so horribly that no one could remain in the same room as the patient was. Whenever the dressing was going on, everyone would just constantly almost puking with the horrible smell. So at that portion, I had prescribed after arsenic alba Huangnan 30. Huangnan 30 within 2 to 3 days removed the foul odor from this infection, this abscess. It reduced the discharge to a little bit less than it was before. But yeah, discharge was there. There was, as you could see, a blood-filled discharge was coming out, and the tenderness of the patient had increased after basically arsenic and Wagner had acted. The tenderness had increased, the pus formation had increased. There was a deep abscess pocket within the dorsum of the foot. So at this point, I had given Hipasal, followed it with Calcareosal 30, which did a very wonderful job. So during this time, next slide, next slide, Orko, next slide. Hello, Orko. Yes, thank you. So basically, again, it's the same representation step by step what had been done. There was a necrotic phase. At that time, carbovesh was given because there was a threatened tissue death at that time. Blackness was arrested, gangrene was arrested to a quite bigger extent. Then there was systemic toxemia, toxemic state, which was arrested by pyrogen. Fever was there, fever dropped. After that, there was a stagnant suppression phase where Dalcama and Silesia was given. go with indication, but maybe I had not given a very good indication for Dalkama and Silesia. This was my failure. I am not saying that the medicines were indicated there but did not work. I think this is my failure that I had prescribed Dalkama at that state at and Silesia after that. But the thing is, the medicines did not work. After that, there was deep putridity present, along with, since there was a small gangrenous part present there. So I had given arsenic alba on the generalities itself, and post which I had given Huangan to decrease the putridity of the abscess part, which did its job and margins had cleared, the odor has vanished. And lastly, for repairing and granulation repair, I had given a Hipersol and Calcareosol 30. First Hipersol when there was tenderness, when there was too much suppuration, where there was too much discharge. And after that, I had given Calcareosol 30, which did its work and dried up the wound very good. So, next slide. Next slide. So basically, there are three parts where pathology evolves, prescriptions must follow. Then reassessment was mandatory, and third, document to decipher. Basically, I had taken this whole part is not mine. Basically, this whole credit goes to the patient's family who took series of pictures. I had asked them to take almost every second, third day to take pictures of the wound. Whenever they were doing dressing, they were doing taking photographs of the wound, and hence I can show you the slide, means show you this presentation so in a very good manner because I have got all the photographs. So next slide. Next slide. Orko. Uh, Co-clinical, তারপরে স্লাইডটা আরো নিচে নিচে যা নেক্সট ব্যাস কি হলো তারপরে স্লাইড কোথায় গেল ও ক্লিনিক্যাল ম্যাক্সিমস এর পর কি আছে অর্ক আর ইউ দেয়ার
Please hold on. Please hold on. There are some network issues from my side. There is a network issue. Hold on. I'm trying my best.
ওকে ওকে
Now you can see.
হ্যাঁ ক্যালকুলাস আউট নেক্সট Is there any problem with the slide?
I guess there is no issues with the slide. Can you see the pictures?
I'm seeing up to calculus solve. Then there is no nothing. My screen is stuck on calculus solve.
Oh, then wait, hold on. Maybe there is some network issues from my side. So that's the main thing.
Yes, I mean, take a second.
Just hold on for a bit. There is a slight issue. It will calculate yourself, right? There is some issues going on from my side. I don't know what is happening.
আমি এক সেকেন্ড চেষ্টা করছি না
Just hold on a minute. I am trying again. I am trying again. Just hold on for a bit.
এখান থেকে স্ক্রিন শেয়ারিং আছে কিছু
Just hold on. Just hold on. I am trying. Just hold on. Network disturbance from my side. That's the thing. Can you just tell what?
Yeah, they actually is almost done. Okay. We will see in the next slides how better the patient is right now. There is healthy granulation tissue present. So now we address the two issues which we any homeopath would face in this presentation. One, the first issue was the why prescribed carbovesh 10m or why prescribed basically pyrogen 10m. So coming to that issue, what I understand is that from posology we know in basically in cases where there is deep pathology, we should always prescribe lower doses, lower potency, and repeated doses would be much better. But I chose to go with higher potency because time was an essential factor. Though it was Aeropoeta, though it was a chronic disease, but time was of vital importance in this whole scenario. We did not have time. The whole scenario, the pictures from start to finish that we are seeing is in a manner, in a whole window of 20 days, not more than that. So that is the whole reason. Just to do a swift work, I started with 10m. I did not go for Cowboys 30, then 200, then 1m, then 10m. I did not go for that. I started with 10m. It did its work. Within 4 days, it did its work. And after that, Pyrogen 10m, when I started with Pyrogen 10m, within 2 days, the fever came down. So this was the whole reason that I used a bigger hammer than small, using a very small hammer repeatedly. As you can see in this slide, this is the last pictures that I have received from the patient. As you can see, this dried up almost and is still doing nothing right now, just doing calendula dressing and normal saline dressing, wash, that's it. That is the only thing the patient is doing right now. Patient is completely off any medicine right now. And the last medicine I have thought of giving to this patient again is again Carbovesh 10 to increase oxidation of the area. Carbovesh has got a very good role in oxidation processes. So in order to improve the circulation of this area, I have thought of giving him Carbovesh 10m even after this photo. So since he's still doing better right now, I have not given any new medicines. The second question which anyone would have in this slide is, why did I change so many medicines in such a very acute way or such a small duration? That's the second question anyone would have. The reason for this again was that this patient was threatened with amputation. He did not thought of having an amputation in this time. He wants to return back to his work. At this time, if we the just to make it swift, or if we don't arrest it in right now, then we had the risk of amputation of this leg. So in this area, that's the reason I had to change medicine so swiftly. Whatever medicine had worked, I used it for swift amount, for less amount of time. Carbovesh 10m 5 or 6 days. Given a break for 5 or 6 days, oh sorry, given a break for 2 to 3 days, given Pyrogen 10m. It worked again. Stopped it after 5 to 6 days. After that, given Dalkamara. Dalkamara used for 4 days only. No work. Switched to Silesia. Did not work. For 4 days, I start given Silesia. No appreciable response. I switched to arsenic alba. From arsenic alba, there was a very good response, but I did not leave it there because there was a putrid smell coming out. And so I switched to Huangnan. Huangnan also worked. After that, there was a deep tissue, there was tenderness. The totality of the symptoms had moved from just a gangrene case to a total case of abscess. So I went to Hippasal, and Hippasal did its job. So just to dry it up, I used Calcreasal. So that's the whole reason. Since the case is so acute, and since the patient is risking losing a limb, losing a great toe, so that's the whole reason I had to change medicine so swiftly. I know it might not be a, it might seem as an excuse maybe, but just for the betterment of the patient, I thought to do this. So from this, we will proceed to our next case. Orko, next slide ta dena. So, this is again, this patient is a little bit different from the last patient, and here approach for the patient has also changed. In the last patient, you can see he had changed so many medicines under so much less amount of time. Within a matter of 20 days, I have given so many medicines. Now in this case, you will see that how a single medicine can do a wonderful work, because in this case I had lots of time and I had less amount of fear. That's the first part. So moving on, let's to the next slide, please. Next slide. एक बार change. So না ওপরে গ্যাংগ্রিনে পরে third slide. Patient information. I have provided the even the name of the patient, which is generally not done in any kind of seminar. So basically, patient's name is Deepak Bagh. He is 50 years old, male fisherman by profession. Basically, when he came to me, he had came after at least 8 amputation operations on his leg. Basically, when he came to me, he came with severe pain in left foot, gangrene for approximately 8 months. 8 months progression. So many surgeries done during this time of 8 months. Basically, 4 foot is already amputated and lost. Persistent ulceration is there, and there is recurrent bleeding episodes. The positive part was that there was no diabetes, there was no comorbidities of diabetes or hypertension. Again, this patient, when he came to me, he was advised for complete foot amputation. Let's go to the next slide. As we said, symptoms started approximately 8 months before consultation. Progressive gangrenous changes developed. All 5 toes eventually amputated. Not all at once, but basically it was amputated one at a time. So there was frequent dressing was required. When he came to me, he was all wrapped around, the whole place was wrapped down with bandages, and the when the bandage was opened in the camp, because this patient came to a free health camp. So almost every patient who was in the room was disturbed, not was just by the visual, but also by the horrid smell. So next slide. Basically, he had so much severe pain that it was also disturbing his sleep. So as you can see, this is the condition in which the patient came to me. Seeing this case, I had almost in the same day, I had to see almost 75 to 80 patients. So in that short amount of time, it was very difficult to see this case where means thorough case taking could not be done. So go to the next slide. If anyone can zoom in the screen, I have taken a very brief case taking. Basically, pain in left foot 8 months ago with gangrene. One to amputate, same episode 4 times occurred, and amputation was done. All 5 toes are amputated. There is tremendous burning in the sole of foot. There is pain in the dorsum of foot. He is a fisherman by profession. Appetite, you can see the is satiety. Second part, thirst is little at a time. He cannot take too much of water, just like arsenic. The third is desire. You can see desire, stool, uncovering, urination, thermal reaction, sleep, everything is there. Even my phone number was mentioned in the prescription below. As you can see, this is not my prescription. I had to mention my phone number so he could consult me further. If you see on the right side, I had started with C. Calicor. Now, the reason for using C. calico in this case was simple, very simplistic. There was too much bleeding from the ulceration, the gangrene, where there is gangrene along with bleeding, ulceration in the area. C. calico is of vital importance. So I started with C. calico, but though his constitution was coming for arsenic alba, and we had a very limited number of medicines in the camp, so started with C. calico. As you can see my prescription, there's nothing to hide. I told him to take 4 globules if everything was in globules itself. I told him to take 4 globules 2 times a day for 7 days. After that, give a 5 days gap and start with arsenic alba 200. That was also in globules. I told him to take it only for 2 days first and report back. And for wound dressing, I had advised to use Echinacea mother tincture. Next slide. So for whatever the particular symptoms were burning sole of foot, pain disturbing sleep, worse during night, recurrent bleeding from ulcer, chili patient, desire for meat, desire for sweet, jaundice. Though I have taken desire for meat and desire for sweets and jaundice into consideration for the sake of this presentation, I did not go through, I did not consider this while prescribing. Next slide. As you can see, it's very much evident from the picture. There is extensive tissue destruction, gangrenous ulceration, multiple sinus-like openings, blackish discoloration, slough formation, unhealthy granulation tissue, and threatened extension of gangrene. He has already lost all his 5 toes. Now his foot is like this. He risked further amputation of the whole foot itself from the ankle part itself, and he was advised for amputation from the ankle itself since there was still healthy tissue there and gangrene had not spread to the further areas. So he was advised for a total amputation from the ankle itself. Next slide. As you can see, C. calico 30 was given. Then after 5 days of gap, I started with arsenic alba. Echinacea mother tincture dressing was done during this fight. So follow up. Next. Basically, before reduced inactive bleeding, before knowing all this part, as you can see, it's very much evident from the prescription that C. calico was followed with arsenic alba. It's not that C. calico was given, then observation was made, then arsenic alba was given. It was not that. I knew C. calico can means arrest the basically bleeding, active bleeding which was taking part in the wound and from the gangrenous part, and I know the rest of the case was to be dealt with arsenic alba only. So arsenic alba was the main medicine, but C. calico I use it just for arresting the bleeding itself. Next slide. uh, though I was doing a camp, but I had got synthesis repertory with me. At that time, the thing which I actually taken into consideration were certain rubrics. As you can see, the rubrics are in front of you. Extremities, gangrene feet, extremities, gangrene legs, extremities, gangrene lower limbs, extremities, gangrene toes, extremities, pain, burning, extremities, pain, feet, burning. All these thing rubrics are present in front of you. As you can see, C. calico is in the top of the list. It is covering most of the symptoms, and arsenic alba is on the third portion. In between comes lachesis. But there was not a single, basically, if objective symptom I am not considering. Subjectively, there was burning pain. The thirst was that of arsenic was the thorough indication. Before repertorizing it, basically arsenic was the first medicine that came into mind, but after repertorization C. calico was quite evident. So for arresting the bleeding I gave C. calico. Next slide. Again, basics of arsenic prescription everyone knows, so we won't waste time here. Gangrene, burning pains, chili patient, worse at night, sleep disturbed by pain, ulceration with tissue destruction. All is covered by arsenic alba. Totality of symptoms is covered. So now we will go to the best part of this case presentation, is that No change of medicine was made. Only arsenic was prescribed. Next slide. Initially, as you can see in the prescription, arsenic 200 has been prescribed. Only 4 doses totally, 2 times for 2 days. This after that, I had given a break for 5 days. Then consulted with the patient. He was doing better, but again the burning pains were returning. The burning pains were better with arsenic. So after 5 days, when the burning pains were returning again, so I had again repeated arsenic 200 again. After 1 month, basically he again consulted me through video call. At that time, I had prescribed arsenic in LM potency. LM potency this time also is not like I generally start with LM4. I don't go for LM1, 2, 3, then 4. I start with 4 itself. I go in even numbers. I started with 4 and I was stuck with 4 LM4 for almost 45 days. That is 3 consecutive times. First 16 days LM4, second 16 days again LM4, third 16 days also LM4. After that, I proceeded to LM6, then LM8, then LM10, then LM11. All follow-ups were made, and single remedy is the only prescription which is continued through this whole case even till now. Let's see the further next slide. Next slide. Yeah. So as you can see, anyone can understand how is the follow-up. The first picture is of the first follow-up and the second picture is of the second follow-up. Now, as I said, these patients are living off far away. For them, traveling is not very much easy. So all these pictures are taken in the patient's home itself, and everything was done by video consultation. No change in medicine. I kept on giving arsenic in LM potency, as you could see the follow-up chart itself. So now let's see next slide. Next slide. As you can see, progress of healing is quite evident. Bleeding has ceased, slough reduced, granulation improved, ulcer area contracted, sinus opening reduced, tissue became healthier. Initial stage, as you can see, the healing trend is also present. And clinical observation, basically progressive improvement noted on follow-up visits, no further extension of gangrenous process observed, and local tissue condition became healthier over time. Healing proceeded steadily under continued treatment, preservation of the remaining foot achieved. So basically, a patient who was told to go for amputation from the ankle did not need any amputation further. Now this follow-up which you saw in the chart is done for from last January to this day. Basically, this is right now June. A patient is right now irregular with medicines, as I have told him, because he doesn't need so much medicines. Still continue on only one medicine, arsenic alba. Next slide. As you can see, all the follow-ups, third and fourth follow-up of this basically both are the third follow-ups. There's a leveling mistake. Both are third follow-ups. Next. Basically, prescription preservation of remaining foot, no major amputations performed, progressive wound healing. Everything is good. Improved quality life. Patient can walk within his house. Patient can walk outside also, with obviously with support of a crutch, but he can walk. And he doesn't need any. After this, he doesn't need any kind of what should I say, dressing, which was constantly done during this whole time. Ishnesha mother was using dressing. Next slide. So this is the last follow-up of the patient. Means as you can see, everything has means become better now. They as almost the yellow parts which you are seeing, there's no such no transudative or exudative discharges from the ulcer gangrene site. Is all good. and patient can walk. There is no burning pain. Nothing is means basically patient is almost asymptomatic right now. There is no not a single episode of pain, no complaint of pain, nothing. Next slide. So basically, discussion of this whole case is that pathological similarity initially indicated C. calico and constitutional and characteristic symptoms favored arsenic alba. Here, the thing is, I could stick with arsenic alba for a long time because arsenic alba was acting. And many, again, the question here is that if we follow homeopathy principles of homeopathy, if you see that if a medicine is working, we should give the medicine certain amount of time for working, give a break before giving the next dose, even for the same medicine, if, or not increase the dose or potency of the medicine. But as I was giving in LM potency, it needs to increase in doses. That too, a single LM potency was being given for almost 1 to 1.5 months, then changed subsequently. So right now he is on LM12 right now. Patient is almost asymptomatic without any problem. Next slide. So basically, this is, as I said, previous case, I had succession of remedies, and the whole case is of basically 20 to 25 days age, because from my the first visit to till the last follow up that I had is basically a time span of 25 days or 30 days. And this patient started from last year January, 26 January, and is still continuing till now. Oh, he's better. He doesn't need much medication right now. He's feeling good, but all his family members are now my patient right now. So this was my part. Only sharing a very small part of experiences I had in my clinic, and basically all credit goes to basically in both the cases. The whole point that the presentation was possible because of the cooperation of the patient's family itself for constantly clicking pictures of the affected side, even though in many parts it was horribly smelling, but still patient kept on taking pictures. Patient was very cooperative. The patient's whole family was very cooperative. Patient's whole family could understand that medicine was working. Patient's whole family had trust on me, and we could basically move further towards a cure. First case is still undergoing treatment, and as I said, the next medicine I've already thought of here repeating carbohydrate 10, and for this I didn't have to change in for last 1.5 years. I did not change one medicine. I am one of those people who would be the first one to say that for a chronic case, you cannot stick on one medicine. That's my view, because one single medicine can't heal a whole case. That's my view. But in this case, this is one of those cases where I personally have felt that only, even if it's a case where it sticks to one medicine enough to cure the whole case. So with this said, I would like to conclude my part and give way to my moderator for further discussion. Thank you.
Thank you, Dr. Argha, for presenting such a nice two cases, which was you have actually shown up how homeopathy can beautifully restore a condition which was at the verge of amputation. And in both the cases, one with a series of remedies and another with a single medicine, beautifully bring back the patient to the normal state. Actually, it depends upon the discretion of the physician and his expertise or experience to approach such cases, how to approach such cases. Especially, that depends upon the nature and the intensity of the symptoms which the patients are suffering. So, thank you once again for presenting such a wonderful case. As we come to the end of the today's session, I would like to hand over the microphone to Dr. Bidyut Mukherjee, sir. Sir, please.
Or is
Excellent
there any
presentation,
question?
Arjun.
Okay.
There are a lot of questions. If you can refer to the WhatsApp, there has been a question
Can
from,
if you can read it, or it would be very much easier for me because
yeah,
I can't see my WhatsApp right
yeah,
now.
yeah, okay. Explain Hongnan use also in the leg ulcer case. This
Okay.
is one question.
See, should I answer this or wait for all the questions?
No, no, you answer it. The question is in your
Okay.
screen.
Simple. Huangnan prescription in this whole case was one of the most easiest prescriptions in the whole case itself. Why? If you go through Mathematica of Huangnan, it is used in the most putrid, horrendous, means any case which can make the doctor puke. That is one of those cases for Huangnan. Means one you can tolerate, don't go for Huangnan. You can think of other medicines with offensive discharges. But in offensive discharge, if anyone, two in my experience, I have seen in Dr. Sunima Sarkar's clinic also, if one medicine which holds the number one position for most horrible smelling discharges, that is going to be Huangnan. So when basically the Huangnan prescription is not done by the brain, is done by the nose itself. The more horrendous smell when a patient is saying that no one can be in the same room when the wound is open or when this discharge is coming out. That is the classic indication of Huangnan. More horrifying smell, the one which you will think means if that smell comes into your nose right now, you will forget about eating. Even being a doctor, when a doctor skips meal smelling a patient discharge, that's one of the clinical indications of Huangnan. This has happened to me in Sir's clinic when a patient came, and that day I had to skip lunch because I couldn't eat. It's not that I was inexperienced. I did not had experience with horrendous smell. I had, but that was the place where everything had to come into a halt. Means after that there was no returning to the same room for means we had to use room freshener in the whole clinic just to get rid of the smell. So that's Huangna. Next question.
Next
I hope I
question
am
is,
able to answer it. If
yes,
possible,
yes, if
explain
possible,
something about the other possible remedies.
right.
See, if other possible remedies, if we go for like this, is if we see first it's an abscess. If you are treating it as an abscess, there is infective abscess. Pyrogen is the first part to reduce the abscess form means reduce the what should I say toxemic state. The second medicine which you can also think about other than pyrogen here is septicemine. It's a rare medicine, but it has got a very good role for decreasing the septemic condition of the patient. The third part is the abscess series itself. If you have got tremendous amount of throbbing pain, you can also think of belladonna here. But when there is discharge, don't go for belladonna. If the pain is not there, is only a discharge is coming out, you can think of Maxol. And in a place where wound is exposed to dampness like wet soil, rain, these kind of factors, dalkamara again is an excellent remedy. But in the purpose of this case, dalkamara did not have any good results. The fourth medicine would be again silesia. Silesia is an excellent remedy. It promotes drainage of pus in any kind of abscesses. If you give repeated doses of Silesia 30 in any abscess, if it has got an opening, it will drain out all the pus. In gum abscess, if you use Silesia 30, repeatedly, you will see means it's within 3 or 4 hours. If it has separated to that extent, it will drain out all the pus within 4 to 6 hours of the administration of the medicine itself. So this is the all medicines which we can think of in this kind of cases. Arsenic alba again a very wonderful medicine for this gangrenous state. So we can talk about a case for each and exact means each cases medicines can differ. Next, I hope I have answered the
There is,
question.
yeah. There
Please
is
guide
another
the
question.
dilution of calendula mother tincture for washing the face. Simple. Since calendula mother tincture means in any simple injury cut, it causes intense amount of burning pain because it's pure alcohol. So in any kind of dressing for this kind of ulceration, for this kind of gangrene, where patient is already suffering from a tremendous amount of pain, always use it with normal saline. That's the best thing you can do. Never use it with normal water, because use it with a sterile normal saline from a which is given for IV. Use that normal saline for basically dressing, irrigation of the wound, and calendula mother tincture for cleaning the wound itself.
That's Dr. Argha, and we are really grateful to our alumni like Dr. Orgo. This is the fourth or fifth time he has been in the CME. He started his first presentation way back in uh, 2021. He started with
COVID time.
during COVID time with Dr. Pralay, our present director, Dr. Jayajit, Nidhi Tiwari, and Dr. Tushar Mittal, evaluation of physical symptoms. In May 9th, 2021. He was here in 90th CME on 24th March 2024 with lumbar spondylosis. Orgo was here on the 99th CME with a case presentation to commemorate pre-centenary CME celebration, along with other 9 doctors. Then he was also there as an inaugurator in very recently concluded CME, not recent, a year ago, 8th September, the 100th CME, as an inaugurator. And this is the commitment. He is here on the 141st CME. NIH Alumni Association are proud of alumnus like you, Orgo, that you had been with our senior stalwart, Dr. Farooq Master here, but still the commitment to go on with the CME organized by NIH Alumni Association. We had conducted the entire session from a hotel itself. So where from there, Dr. Farooq Master will be addressing small
No, Dr.
videos.
Farooq Master went to his room.
He'll be here
He was
on
very much tired. He went to his room.
he'll be there on coming Tuesday, 16th of June. And if anybody want to learn from her, I think very limited seats are there. And so the details is already shared. Get in touch with us in the comment box, or with Dr. Orgo, or with us, and we'll be guiding you through. And we like to thank
The
Dr.
only
Akshaya for a valuable input. And Dr.
the
Akshaya
only
also being
part
an
I would
alumni.
like to say,
Yeah.
the first part before introduction itself, the thing was everyone did not know what to use to introduce me. The best introduction for me is that I'm from 22nd batch UG NIH. That's my introduction. That's the best introduction I can have, because I'm proud of where I am and I'm proud of where I was. And today I admitted in front of all of you where I have failed, where I have done a little bit better. I have presented in front of you. That is all credit due to because I was a part of NIH.
Yes, we all agree with that, and this is what we think that through this CME we can help each other to develop homeopathy instead of presenting decorative case. we have to discuss our success as well as failures. And we are proud to have tonight also Dr. Robin Sarkar, a very bright student from 30th batch EG of NIH, now in first year of MD at the Calcutta Orthopedic Medical College and Hospital. The background team who are working day in, day out, our Assistant General Secretary, Dr. Syed Afsar Ali sir, and Dr. Naeem, Dr. Tushar Mittal, Dr. Chandrasekhar Pore, our President, working President Dr. Ujjal Mondol, and a lot of others who had been working day in, day out to make this Alumni Association program going successfully. We appeal again to all the alumni across the globe, whoever is watching this and will be watching at a later date. Please don't hesitate to approach us. Get in touch with any of your teachers in NIH who whom you are having access to, and be a speaker here, be a resource person here. Share your failures, share your success, and we'll learn from each other. That's the purpose of NIH Alumni Association CME. Thank you. And with this, we are going to meet again on 28th of June with another set of press presentation, which will be done by Dr. Kaveri Pandey. So till then, good night and stay safe, stay healthy, and promote homeopathy to the greatest extent. And in spite of having World Cup football, Women's World Cup T20, we had with us 48 live viewers watching this show. And I hope there will be several thousands more in the coming days. With this, I'm returning to our backstage editor, Dr. Orko Mukherjee. Good night.
Good night.
And if you have enjoyed, do make sure to give it a like, share it with your fellow mates, and don't forget to subscribe our channel to get more CMEs like this. And also before that, if you want to get generated e participation certificate, then all you have to do, just go on the link given in the description below, Google form link, click on that, fill up some details, and after that you will receive auto generated e participation certificate in your Gmail if the Gmail is valid and verified. So again, one more thing is that the link will be live till 12 a.m. After that, the link will automatically get closed. So hurry up, guys. Get your auto-generated e-participation certificate. And if you know, in current NCH format, the e-participation certificate in online CMEs and offline CMEs in different courses, not uh, only with this, but also in any other CMEs, the participation certificate is very much important now as per the NCH order. So you know the importance of this. And also, this is it, what nothing needs to say like this. And also, those who are watching from Facebook, do share it on your wall if you liked this CME. And also, you can just share it on Messenger to other friends who are not on WhatsApp or not on Instagram or not on YouTube. So that's it, that's the main thing. Oh, and one more thing, you can join our WhatsApp channel. The link is also in the description below. You can join over there. And also, we had a Spotify channel of a Spotify podcast, though it got discontinued, but we are trying to restart it as soon as possible. We are trying to get, since we have a less manpower. So that's the thing, but it will soon start. And for all of you, it will be available then. You can just listen to the main part only, to everyone also. That also, we are excited that we can share with you one more thing, the CME highlights. You can go check our channel on YouTube. There are some things, there is a playlist called CME highlights. We have uploaded only the two parts, and we are trying our level best to get upload just to edit and upload the rest of these parts. We are trying our best, but don't worry guys, we will also continue that too soon, either this year, either this month, or within 2 to 3 months or so. The time will say. But for that, you have to just subscribe our channel, and don't forget to click on the notification bell to get updates, and also join our WhatsApp channel to get updates over there too. So with this, thanks again. Thanks for watching. Good night. See you in our next CME. Until then, it's me, Dr. Orko Mukherjee, with you all.
This channel does not promote or encourage any illegal activities. All contents provided by this channel is meant for educational purpose only.